Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes. In this first episode of our new series on health literacy, we sit down with Dr. Catina O'Leary, President and CEO of Health Literacy Media. Together, they explore how clear, human-centered communication can transform patient care, from the front desk to the exam room, and why meeting people where they are is essential for better outcomes. Let's step into the exam room.
Welcome back to the exam room. Today we're taking a closer look at effective communication and more specifically, how we can leverage it to drive health literacy. And joining us today is Dr. Catina O'Leary. She is the president and CEO of Health Literacy Media and a national leader in making healthcare communication clear, actionable, and human-centered. With a PhD in social work from Washington University in St. Louis, and extensive experience helping organizations improve outcomes through better communication, Catina brings a wealth of insight to today's discussion. Together, we're going to talk about how health literacy starts at the front door of the health center, why communication is key to behavior change, and what providers and leaders can do to build a truly health literate organization. Catina, welcome to the exam room.
Thank you so much for having me.
So you spend much of your career helping healthcare organizations communicate more clearly and effectively. Can you just start by sharing a little bit about your journey and what led you from social work and academia into the field of health literacy?
Thanks for asking that question. I started way early on in my career. My mother was the executive director of a large mental health facility down in rural Missouri. So I grew up in Kennett, Missouri. It's the Boot Heel part of Missouri that's down in Arkansas. So if you cut off the bottom of Missouri, down in Arkansas, that's where I'm from. My first job was as the treatment tech that went into a substance abuse treatment center out in rural Missouri and worked from midnight to 8 in the morning with kids who were in residential drug treatment at night. So I sat there all night long in this old schoolhouse, and my job was to every night at about every hour go and check and make sure all these kids were still in their rooms safe and sound, and they were doing what they were supposed to be doing. And from that, I thought I wanted to be a social worker. And I was certain that I wanted to be a clinician, and I wanted to help people with substance abuse problems. First, I started in psychology. So my first degree was in psychology, but then I ended up in a social work course and thought that was fantastic. And so I applied to a social work school and got in at Washington University in St. Louis. When I did my first practicum at Barnes Hospital, it was a clinical practicum in the substance use wing at Barnes Hospital, and I realized in about a month and a half that there was no way I could be a clinician. I just couldn't do it at all. It was so hard. Behavior change is a challenge, right? Working one-on-one with people while they're doing the hardest things they'll ever do in their life, and they just, are struggling to change their behaviors, and you're the lifeline, was more than I could do standing in front of them every day, right? I'm halfway through a degree at that point. I'm completely invested, and I think, what in the heck am I going to do? And as luck would have it, the person I worked with in my clinical practice also worked in research. So I went over down the hall and I got my next practicum in behavioral research. And so I started to work with the group there that had a lot of funding to do lots of behavioral research and substance abuse. So I spent the next 15 years doing behavioral research, HIV prevention, and drug abuse research. So just completely tripped into this. And it was fantastic. I was really good at it. I loved it. I learned to ask questions, collect data, do data analysis, do sort of the backside of learning how to help people without sitting in front of them and being the person that actually held their hand while they changed, right? And it was great. It was a wonderful, wonderful fit. And I loved every minute of it. But about 14 years ago, my mentor at Washington University got a job to go to the University of Florida in Gainesville. And my youngest son was being born. So I've got two kids here in St. Louis, little bitty bitties. My whole family's here in St. Louis. And I didn't want to go to Florida. I couldn't imagine uprooting my whole family. And so my whole research group goes there. I'm sitting here by myself at a university. I don't know if you guys know this, but it's really hard to be in an academic medical center with no research group. So all by myself here, trying to do research in this big academic medical center with no research group where I'm supposed to be NIH funded. So I get a call from my department chair and he says, you still got a job. It's really great. You can be here. You just need 2 NIH funded R01s next year. The bottom had dropped out of NIH funding then, kind of like now. I didn't have any funding of my own. And so I'm pretty much just sitting there. Somebody else said, you can teach. I'm about as good a teacher as I am clinician. I can sort of get by, but it's really scary to me. And so I'm thinking, what am I going to do? How am I going to figure this out? And the world sort of takes care of you. A person that my family had known for years and years and years had started this nonprofit, Health Literacy Missouri at that time. He ran into my parents and he said, again, 200 miles away, I'm really tired. I've been running back and forth to St. Louis because the leader of this nonprofit that I'm in charge of recently resigned. And we've been working with this global search firm trying to find somebody to take the CEO job. And we're having the hardest time. And so my dad says, well, what are you looking for? And so this guy describes this job. And my dad said, well, that's kind of what my daughter does. I've never met this man, but my dad's known him. And so my dad sort of describes me and he describes the job. And the guy says, well, you should have her send her resume in to this search firm. So I send my resume to this search firm. The search firm calls me. I do 9 interviews, cognitive tests, all this stuff. They've been looking for people for 18 months around the world. And they end up hiring this girl who lives 6 houses down from the board chair's dad. Like my dad lives 6 houses down in Kennett, Missouri. So random. Never met this man in my life. But it was just a fluke. So how did this happen? What's the real connection? Social work and health literacy are really the same, right? At the core. So this idea of meeting people where they are, thinking about what they actually need, the focus on, how do people get what they need to do what they need to do, and creating organizations and systems that work for people in a way that's much more simplistic than all the complicated things we create. Justice is a core. Right? It's not about what we needed as a system or policies that are complex. We're not creating things that work for systems and organizations to get rich. And we're creating things that work for people and communities. And conceptually, when we do that well and people do well, systems flourish, right? Communities flourish and everybody wins. That's at a core of social work. That's at a core of health literacy. And that's what I was able to sort of say and do well. And as luck would have it, that then taught me how to do health literacy. But total fluke, I didn't even know what health literacy was. It just sort of aligned so well with social work, which aligned so well with sort of what I learned to do as a kid from Kennett, Missouri, which is a small town in the middle of nowhere where, everything that you needed to do was about sort of helping each other, doing a good job to make sure everybody's okay, which is what you learn in the middle of nowhere, in the middle of the country, where everybody needs to make sure everybody's okay, right? I mean, this sort of small town value kind of thing.
I love that so much. Thank you for sharing your journey with us. And, behavioral change is right in your wheelhouse. I'm so excited to kind of unpack that a little bit more. First, I just want to say thank you for the work that you're doing. Secondly, can you tell us a little bit more about Health Literacy Media and what you guys are doing there?
So Health Literacy Media is a small nonprofit. We sit in St. Louis, Missouri, but we work all around the world. I mentioned when I came to HLM, we were actually Health Literacy Missouri, and that's really important because it's a big shift. So Health Literacy Missouri is a nonprofit that was started by the Missouri Foundation for Health. The Missouri Foundation for Health is a conversion foundation in Missouri. It lives in St. Louis, but conversion foundations are the foundations that are formed when large other big companies that are publicly funded are broken up and converted from sort of private to public, or public to private. I'm saying it backwards. So basically, one of the big blues broke up, and there was a whole bunch of money that had to go into public good. And so this is a foundation that was formed, and they had millions and millions of dollars, and they have to use a certain amount of it all the time. So in Missouri, we have this foundation, and they had to spend a whole lot of money. So one of the things they did is they spun off a couple of nonprofits in the early 2000s. One of them is Health Literacy Media, which was Health Literacy Missouri. So they made this company, and the whole job was to create health literacy in Missouri. So that's about the time that the Surgeon General was talking about health literacy for the first time in the US. A prescription to end confusion came out, and they were starting to talk about what needed to happen for health literacy in general. So here in Missouri, nobody was even talking about what health literacy was. So this company comes up, the universities here are part of developing it. So all the universities get together and they think, okay, the Missouri Foundation for Health has this money. They want to focus on health literacy. What can we do? They agreed to create this company. We were developed. The first thing we did was hired a bunch of journalists. They started putting stories in all of the newspapers to help people understand what literacy and health literacy were and how this mattered to people. They started to put together sort of cohesive groups of people to talk about what you could do in communities to create health literacy. They started to create sort of little work groups in communities to start to create opportunities for communities to work together. They started to basically create core groups to make materials for people. So we had all these services that we just gave away everywhere in Missouri. And we had a couple $1 million at a time to do it. It was fantastic. And then about the time that I got there, the leadership at the Missouri Foundation for Health changed. They determined that it's not the best model for foundations to fund infrastructure for nonprofits. They determined that it would be really good if we funded ourselves. We got to be further spun off, and we got to start to fund ourselves at that point. We had been around long enough that we had some relationships, but most of them were in Missouri. And what we couldn't do is tell folks in Missouri, you've been getting all this for free all this time. Now we need you to pay for it. Mm-hmm. So what we had to do is figure out how to keep doing what we were doing in Missouri, mostly for free, but get money from folks outside Missouri so that we could basically balance it and pay for what we were doing. We started to do that, but when we started to do that, nobody outside Missouri thought that it was necessary to pay for a company called Health Literacy Missouri to come do work in, say, like Philadelphia. So we changed our name to Health Literacy Media because it was also HLM, and then we converted. So what we did and what we do is we develop, design, and create new materials with partners. So those are print, digital, video, social, any kind of materials like that. We co-create materials and messages. We review and revise materials and messages for partners. We test all these with all of our intended audiences to make sure that they resonate. We have an educational set of materials on living organ donation called Explore Transplant and Explore Living Donation. We use that with transplant centers all over the country to help people that are in the process of getting transplant to understand what they need to do. So we work with dialysis centers and transplant centers, and we help people work through that process. We do a ton of work in public science communication. We translate clinical trial summaries, informed consent documents, all kinds of clinical trial information, and we just make information more clear. We do lots of education for folks. So we go into companies and we talk to people about how to do health literacy work. We create policies with folks. We create lots of websites. So anything we can do to implement health literacy policies for folks, that's kind of where we sit. It's fun.
That's amazing. Is there one thing that you guys are working on now that you're like super excited about?
There are a lot of things that we work on that we're super excited about. I mean, I think the things that we spend the most time on is all of our clinical trial work. I mean, we spend a lot of time in that space, and it's exciting and important. But the other piece is really the transplant education work. So we got a grant earlier this year from HRSA to sort of revise a lot of materials and support NALDAC to help people understand how to get resources to get reimbursed for transplant processes. So if you're a person that gets a living organ donation, your donor can actually get reimbursed for the expenses associated with giving their kidney or their liver or any other body part that they provide to you. And that's a big deal because if you donate an organ, it costs a lot of money in terms of time away from work and things like that. But a lot of people don't understand that that can happen. And so, or the financial cost can be a real barrier to folks. So we get to support helping people understand what that looks like. And we're pretty excited about that.
That is amazing. I think raising awareness about living donors, I don't think a lot of people even think about that.
No. And, it's really interesting because there's a huge gap in organ donation. So people are walking around and they need kidneys, for example, and all these people are on dialysis and they really have a real challenge in their life because they're on dialysis and they're having a lot of pain and they're not able to contribute to their lives in the way they want. And there are so many people that could contribute to them, but they're often afraid to even ask anybody, or they may not know that somebody in their family would even be eligible. They don't even know that they could have a living donor, right? So some people don't get on the wait list. Some people don't ask anybody in their family. Some people don't even realize those are opportunities. So we spend a lot of time with that conversation. And then once people know that they could get a living donor, many people don't understand that it's affordable. And so we want to make sure people understand that there are ways to help make that cost a little bit less restrictive. So, we want to talk about what that means. So exciting stuff.
It really is. And it just underscores, I think, the importance of communication and how it's a cornerstone of this concept called health literacy that you and I both know is super important for our patients to be able to self-manage and to care for themselves, get the care that they need. Maybe for our listeners, could you help kind of connect the dots between communication, cost, and quality, and maybe what that looks like?
We assume that people know what they're supposed to do for their health. And, we make these assumptions all the time that people understand their bodies, they understand what they're supposed to do. But it's pretty striking misunderstanding. Most people don't understand what's going on with their own body, the people around them. They don't understand what level of sick they are, what level of care that they need ever. So, for example, my dad died of a sudden massive heart attack. He's walking down the street one day saying he feels bad. And we said, oh, should we go to the doctor today? And he was like, oh, no, I'll go next week. I've got an appointment. I'll talk to so-and-so. That's on a Sunday. Monday night, he's like, I don't feel so good. My shoulder hurts. He goes to the doctor the next morning and he literally dies that day. I work in healthcare. My mother worked in healthcare. My dad had insurance. Overeducated people, this is not an unusual story, right? This happens to people. These are the kinds of things that happen. People don't know when a fever is too high. They don't process, at what point, an infection is too bad. All of these things, like we don't notice when things cross the line. First of all, that's a health literacy issue. And we don't have good ways of checking on any of those things. And when we do check, there's a cost associated with it, right? What's the difference between showing up to a primary care visit, going to the urgent care, showing up at the emergency room? All of those things have different costs. All of those things have different quality. It's a big deal. I personally, right now, I'm between primary care folks. So it's taken 4 months to get a new primary care provider. And then I've got 3 specialists and I don't know which one can treat something. So I sent a note in my EHR 2 weeks ago and I asked a question. The person my specialist sent me to get a lab test. The lab test said everything was okay. So they wrote me back and said everything was okay. And I said, well, everything is okay, except these 2 things say that they're out of range. And they said, well, those 2 things out of range don't matter unless these other things are out of range. So the doctor said, don't worry about it. And I said, well, I understand that those 2 things don't matter if those other things aren't a problem, but I'm having this other problem. And so it is a big deal. And I need the doctor to tell me what to do, like what other doctor to see. Oh, I didn't know that that's what you wanted, but that's what I wrote in the EHR. I mean, that's the note I wrote. And I wrote that note because I didn't want to come in and see you and pay a copay for you to tell me to go somewhere else, right? Like that was the whole point. I was trying to control the cost. Oh, okay, well, we'll have him call you. So 4 more days to go in 2 more weeks. So then, it's sort of all the sort of steps that you have to go to. And that connects again. So what's the symptom? Where do you go? What's the quality that's connected to that? Because you have to sort of weight all the steps. And then that changes what happens to your symptoms. It could potentially be 3 or 4 different quality steps, cost steps. And how does your healthcare change along the way? How do your symptoms change? And you have to be really comfortable with who you are. You have to be really empowered to do that. I'm pretty comfortable with myself. I have a PhD. I work in the health system. My language is pretty good. For a lot of folks, they're not in that situation. A lot of people couldn't even be comfortable even risking paying one of those copays, much less 3 or 4 of them. And I mean, think about it right now. I mean, we're looking at a case where we don't know if people are going to get paid their SNAP benefits this month or not.
Yeah.
So what does it mean when you don't know where you can go to get checked or not? We need that communication to be clear. We need to know that when you sign into your EHR and you send a question, somebody can send back something clear and let you know exactly where to go in one trip, one copay, and tell you exactly what you need to do in a set of messages that are really, really clear. And it needs to be a bullet or a note or a very specific step of where to go and what to do, not 4 or 5 pages of instructions that don't really apply to this problem. They might apply to a bunch of other problems or things that are kind of related. I mean, you see that happen all the time as you go to the doctor and, you say, you saw my kid for this, that, or the other, and then they send you all the connected resources for everybody that's a 14-year-old. Well, I don't want all of those things. I want the specific instruction that you need me to have today. I need
Yes.
that instruction. And again, the over provision of information and resources isn't good communication for folks who have a gap in health literacy. It's not helpful for anybody. We all need exactly the specific information that we need now. And we'll let you know if we need more. But we all want to know exactly what we're supposed to do. No more, because it's too much. It's all coming at us from all directions. So again, that's too much information. We don't know where we're supposed to go. It's coming at all directions. It costs us more than we need. And when we get it wrong, we often give up and then we get sicker. So that makes our outcomes worse. But if we do it right and we get the right information and we get it at the right time and it works out for us and it only costs exactly what it's supposed to, which is not much, and we get well, it strengthens our outcomes and we build, right? It's a reinforcing feedback loop and it goes the right direction. And so that's what we need. We need to build on good outcomes instead of sort of tear down people's trust and sort of go in the wrong direction. And that's what's happening more and more is that we're going in the wrong direction and we're taking people's time, we're taking people's resources. We don't ever see the right people over and over again. We don't have relationships. We can't ask a simple question. We send something into the void. We don't get an answer to our question, and it just doesn't work.
Yeah, I have a friend who was in a really terrible car accident. It's been quite a few years, but it was not too long after her accident. She broke her neck. There's a whole bunch of injuries. So finally, she has a provider that refers her to pain management. So she goes and she sees this pain management doc, and he says to her the first thing, well, it's probably just all in your head.
Right. What would make you think that?
4 years it took her before she got brave enough to go back to another pain management clinic specialist to get the care that she needed, almost having crippling pain for all of that time and just doubting herself. I'm not a medical doctor, but I have been teaching for years. And I remember one student going to my campus director and saying, I don't like being in Dr. Windsor's class because she uses too big of words. So then my campus director and I talked, and she's like, try to remember what it was like for you 30 years ago.
Right.
And sometimes I fell into that same trap as well, as I think we do when we tend to get to a point where we're subject matter experts, like we've just been doing this forever. And sometimes we forget about that.
We talk about this a lot. When I give a health literacy talk to professionals, I try to make the point that we often talk to each other. And we do that because it's a shorthand. And it works if we're talking to each other. We're the same audience. And so if I'm talking to another social worker and I'm trying to communicate in a shorthand for them or for the chart, and I'm doing that for a billing code or another reason, then that's okay, right? Yeah. We know what we're saying. That jargon makes sense. It's even useful. But when I'm talking to a patient or a family member, then the shorthand doesn't work because they don't know our language. So we always have to just keep in mind who's the intended audience and what's the purpose of the communication. And we don't always get it right. We mess up all the time. But when we see that people aren't hearing us, when we actually look at people and we see their confusion or we feel their nervousness, at some point we have to look at people and sort of key in and recalibrate. That's sort of what we need to do as humans. And we're not always going to get it right, and we can't beat ourselves up when we don't. But what we need to do as humans is commit to trying to take that moment every time we can. And when we notice we're doing it, take a breath, recalibrate, and then re-engage.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.